All right, so just a little bit about our two excellent speakers. So Dr. Miller is an experienced clinician with an expertise in anterior segment disease and fitting a wide variety of specialty contact lenses. She specializes in therapeutic contact lens fittings for patients with keratoconus, corneal scarring, post-surgical eyes, aphakia, ocular surface disease, dry eyes, and other complex corneal diseases. She has extensive experience with prosthetic contact lenses, scleral lenses, and specialty contact lenses as a whole. She also fits contact lenses for astigmatism, myopia management, multifocal contacts, and infants. Dr. Miller enjoys providing comprehensive eye care for patients of all ages and monitors conditions such as diabetes, glaucoma, and macular degeneration. She's also involved in research endeavors, lectures at national subspecialty conferences, and provides clinical education to optometrists and students as a consultant. She lectures and publishes on topics related to dry eye, anterior segment disease, and specialty. Dr. Jamie Kuzniar is the owner and founder of Elevate Eye Care and Eyewear in Rochester Hills. She received her doctorate of optometry from the Michigan College of Optometry at Ferris State University. After graduation, she completed her corneal disease and contact lens residency at Indiana University. She's been the recipient of many awards and accolades, such as the Clinical Excellence in the Field of Gas Permeable Contact Lens Award from the GPLI, the George Mertz Contact Lens Residency Award, and was voted by Newsweek onto their list of top eye doctors in America in 2021 and 2022. She's a fellow of the Scleral Lens Education Society, as well as the American Academy of Optometry, is an advisory board member for the GPLI, and she's a consultant who lectures nationally to students and doctors, teaching them about new technology and specialty lenses, dry eye, and keratoconus. I welcome both of you, and I'm so excited to listen to your webinar called Jumpstarting Your Scleral Lens Practice.
Thank you so much for the introduction, and thanks for everyone for taking time and being with us here tonight. This topic is something that I'm really excited to talk about with Dr. Kuzniar because it's something that is heavily weighted in my practice every single day. It's an area where I'm really passionate, and it truly is a really rewarding experience. So for those doctors that already have a scleral office, hopefully by the end of this, you will get something that maybe can enhance your scleral practice. And for those of you that are thinking of adding sclerals to your office, hopefully at the end, we've answered all your questions, or at least got, motivation and the resources necessary to really get started with your scleral practice. Let me click here. Our objectives during this hour is going to be to really be able to have indications for who are those patients that we want to fit for sclerals, and considerations on when we are thinking of scleral lenses, how to establish a scleral lens practice within different settings. As you'll hear, Dr. Kuzniar and I, we work in different location type of settings. So hopefully, depending on where you practice, whether that's corporate, hospital-based, private practice, you get a little bit for all those different locations and resources on how you can get started there. And then how do we find these patients? Where is this referral network? And like I said, those resources. So when we're thinking about, scleral lenses, and we're thinking specialty lenses in general, it's kind of like, where do we find these patients? How am I going to start with billing? I don't even know how to bill specialty lenses. How do I schedule these patients? What type of instrumentation or fit sets do I need to have in office to get started? Consent forms. You start making this list of all the things that you're going to need, and it can seem a little bit overwhelming. Where do I start? Well, Jamie and I'm going to refer to you as Jamie.
That's totally fine.
I like she's we both have a little bit of background that's a little bit different on kind of where we got started and where we are now. And so before we went into kind of our recommendations or feedback on kind of what we do, I thought it would be important for us to share a little bit about ourselves, so you know where we've come from and where we are now. I did a cornea and contact lens residency following being at SCCO, and from there I went into private practice, and I actually worked at 2 different private practice settings building their specialty lens office. They didn't really have specialty lenses. They really wanted to have that service available. And so scleral lenses was one of those big opportunities for those offices to add. I worked in private practice for about 2 years. And given that I'm from Northern California, there was a great opportunity to work closer to where I'm from, close to my family, but also have the opportunity to use everything that I learned in residency in a hospital-based setting. And so I currently am working at UC Davis Eye Center, hospital-based. I've been here for almost 8 years, and my practice is very heavy on specialty contact lenses with a huge emphasis on sclerals. And we'll kind of go through a little bit of how I've built my practice here, and some of the internal avenues that I already had established before even coming here. But Jamie, give us a little bit about yourself.
Sure. So like Heidi, I did a cornea and contact lens residency after graduation. And then when I left residency, I actually joined a larger OD group practice. And when I was joining that office, they had fit, a scleral lens like here or there. They did, gas perms, ortho-K, like a lot of other things, but not scleral. So the thing that's difficult is when you leave residency, you know a lot about how to fit sclerals, but you don't really know how to run a business of sclerals. So joining that office, it was really like, okay, how do I educate this staff? How am I going to train this? How am I going to train the techs? How am I going to bill? How am I going to code? How am I going to get scleral lenses incorporated into this really busy established practice? So I was there for 5 years. And then 6 months ago, I actually opened up my own cold start office. So it's been about 6.5 months where I see about half of my patients are scleral lens patients. So, I took a lot of that knowledge, business knowledge there, and just moved my patients to my new cold start. So a lot of questions people ask me is, how did I get, scleral lens referrals to a brand new cold start? How am I, working with only 2 staff members and seeing all these scleral lens patients? So that's something that we're really going to focus on. With Heidi having a really busy hospital-based practice and me having a very, bare bones cold start practice, and, how we both do it.
And as we go through, if questions come up, please add them to the chat. We may not address them right then, but I think it's really important that we answer these questions because we have a lot of people on the call tonight. And some, like I said, might already have a scleral office, but maybe it's not that busy and they're trying to see how they can grow and enhance that office. But I think asking these questions will really spark some more diving deep into some areas that maybe will help other offices as well and other doctors on the call. So we wanted to start off with first what are some advantages of scleral lenses? And I'm sure all of you know plenty of advantages and can think of a few patients right now as we're going through this. So you say, oh yeah, I think that they could do well in sclerals. But we wanted to just, review and harp that the vision is going to be similar or enhanced compared to corneal GP lenses, and really make sure that the patient is aware of that when moving in there. But some of the other highlights are that for a patient that maybe is not having as stable of a lens, whether that's with a corneal GP or even a soft lens, that they're going to have a really stable lens that is not going to be popping out of the eye. So think about those patients as we go through. Maybe you continually are hearing, yeah, it pops out every now and then when my eyes get dry or it's not comfortable. And people that you're really wanting a stable lens on the eye so that they get better vision will be a great candidate for a scleral. You're not going to get lens dislodgement. And the lenses are really comfortable. And the way I describe it to patients or even my technicians and staff is, sclerals are big. Soft lenses are big. So when we're comparing them to corneal GPs are great. I have a ton of patients in corneal GPs, but for some of those patients, they still just never built up that adaptation where they feel like it's comfortable. It's always something that's in their eye. And with sclerals, when they're fit correctly and with good alignment, they're comfortable. So that is another huge advantage on someone that may be on the brink of dropping out of contact lenses. Also, for those patients that have dry eye, whether it's clinically diagnosed as ocular surface disease or just having dry eye complications, and again, might want to be dropping out of contacts altogether, sclerals can be a huge asset to these patients and help kind of give them back their life. Dry eye can be very debilitating, very uncomfortable, very painful. And if that's all they're thinking about all day is their eyes, giving them something that can get them comfortable again is huge. So think about those patients where they want to be in contacts, or maybe their prescription is so high and they don't really like glasses for all the time wear. They're heavy, weighing on their face. These are all, great advantages of scleral lenses. And then finally, protection. I have quite a few patients where maybe it's not a seeing eye per se, like a really good vision, but they're having neurotrophic corneas. And so these people, we put them in as more of a cover shell. And it's really to get them going back to that, what we're talking about with comfort, making sure they're comfortable, keeping the eye healthy. So these are all great things with sclerals. So as we go through thinking of candidates, I'm going to just briefly go through these, but these are patients to be thinking about in your practice. Do you have patients suffering from ocular surface disease? And, like I said, it could range from just dry eye related to even a soft lens, all the way to someone with Sjogren's or Stevens-Johnson's, the more advanced, complicated dry eye issues. To think of the full spectrum when you're thinking about your patients, and not just thinking that sclerals are only for the most extreme cases. I've started, and Jamie, you can chime in, but in my office, in my practice, a lot of times sclerals become more of a first line rather than making it like a saving grace at the very end.
Right. I'm not making people, drop out of corneal GPs and then drop out of hybrids and then drop out of soft lenses. A lot of times, like, this is just our go-to at this point for a lot of patients, just because it's so highly successful and it's a healthy lens.
Right. And then other candidates to think about are ocular trauma. If you're having an irregular cornea in general, these sclerals are going to really help enhance that. And with the scleral lenses, through the symposium of all the different lectures that hopefully you all tune into all of them, they're going to be fabulous. But you're going to see that there's so many features now with sclerals in terms of adding toric optics, in terms of adding multifocals, vaults, all kinds of things that they just continue to improve, that for someone that maybe you thought wasn't going to be a good candidate in a certain lens, it's almost, I don't want to say impossible because now we're saying absolutes, but I feel like it's almost impossible to not be able to help this person and get them seeing a lot better, because there's just so many features now and coatings and things that we can help these patients see better. When we think about corneal disorders or vision improvement, we're thinking of, the typical people you think about with irregular corneas: keratoconus, pellucid, keratoglobus, your post-surgical eyes. I have a lot of patients right now coming in from RK where maybe they were able to go 10 years with their glasses or without anything, but now it's just the variability from that RK throughout the day, or the ectatic areas that they're getting now from those incisions. They're coming in, and sclerals has been really great for these patients because it does help with that diurnal variation that you can get in your vision by just helping stabilize with that scleral contact lens. So those are great candidates for that. Intacs, my corneal surgeons aren't doing intacs here, but we still see intacs all the time. And so with intacs, they just made our life harder, right? Fitting a hybrid or fitting a corneal GP. I don't know about you. I'm always like, they added a speed bump to this patient. And then remembering that with corneal scarring, these are always going to be patients where you see a scar. And again, Jamie, I don't know about you, but sometimes I'll see scars like right in the center of a vision. I go, I don't know if this is going to really improve. And I am pleasantly surprised when I put that scleral on of what their best corrected vision is.
I know I'm always very guarded if someone has like a central scar, but it's amazing how much improved their vision is, even if it's just, a couple lines. But a lot of times their night driving is better. Their overall quality of vision is better than it was like in glasses or soft contact lenses.
Yes. So throw a lens on. That's one of the key things. I have ophthalmology residents that work with me. And whenever they're shadowing me, they're like, would you put a lens on that? They can't see out of that. That's a very dense scar. And I always say, well, we never know unless we throw a lens on. And so I am a firm believer of throw a lens on and see. Doesn't mean you have to go through the whole fitting process, but in terms of being able to, see if there's going to be vision improvement before you go through the entire fitting point, I think is really important. And let's not rule out the scars. And then again, how I mentioned those neurotrophic corneas, this works great. Some of those people, it's kind of a 2-in-1, right? We're treating the neurotrophic cornea because there's some sort of underlying either limbal stem cell or something that's going on that's creating that neurotrophic cornea. But then we're also helping address the scarring that they have, their regularity there. So these patients tend to see a lot better in GP lenses in general, but with sclerals, we're kind of covering a lot of bases there.
Another interesting point.
Yeah.
Oh, yeah. There was a question. No, a quick question that was in the chat. Another really interesting point is scleral lenses for patients with prism.
Me too, but you don't.
Yeah, I think that is a great option for certain prism patients. So I have fit patients with vertical prism and scleral lenses. There is limitations to that. Have you been able to fit any yourself, Heidi, with prism?
Yeah, so oh, is someone not muted?
I think it's just maybe Dr. Tucker, if we can mute her.
Oh, okay. Yeah. So yeah, I have fit some with prism, not a lot, but there have been some patients, and I'll kind of touch base on that when we get further down. They've been impression-based sclerals where I've done some prism in, and it's worked really well for some of those patients. Usually I will prescribe prism into the glasses depending on how much that's going to affect thickness. You know, there's other things we're thinking about when it's related to sclerals in terms of complications.
I don't know, but now
so
they're wanting
it really
been nominated for testing for gifted and talented again. They want to.
I don't have the ability to mute
I
Dr.
guess,
Tucker.
but, you know, like.
I would just keep going.
Okay. I wasn't sure if one of the other people could. Okay, that is fine.
What's your
it's for other doctors think about is a lot of times we rule off some of the higher prescriptions. We don't think about sclerals as the initial go-to for someone with maybe like high myopia or high multifocals. It's just, it's not in our blood. We've always thought like go to soft lenses, but there are those patients where, higher prescriptions, or maybe they have astigmatism and a high prescription, or just astigmatism in general, and you do the topography and you realize, this is going to be a really tough, bi-toric fit, or this is going to be really tough to do a custom soft toric multifocal, and they want the world right. So these are patients that would also be good candidates for scleral lenses, because sometimes, we can mask that astigmatism with the scleral lens, and then we're just dealing with a multifocal. So it takes away some of the complexity that maybe would come with a soft lens, or if we're already going custom, they already have some dry eye. So think about these patients that are there, and maybe you have that person that's in a multifocal lens, but they're constantly, even though you have them in the Cadillac of soft lenses, they're still saying that they're getting intermittent blurred throughout the day, and they're still having dry issues even with all their tears that they're using, or stasis, or all these different things. These could be good patients to consider for a scleral lens and still achieve all of those goals that they're wanting with their soft lenses. And then finally, I just had to throw in Steph Curry. I'm from California, and he, as a lot of us know, has keratoconus. I don't know if he's wearing sclerals or not, but I would think maybe as an athlete, he'd want that stability and comfort, so that he's wearing scleral contact lenses. So I had to throw him in, but that's the main purpose for him in this altogether, is think about your athletes, like baseball players. Again, I've had some patients where they're corneal GP wearers, but they were saying when they're doing some of these fast moving sports that, they'd look too quickly and something would pop out. And so those are people that I thought, I think it's time to switch you over to scleral, and they've been really happy with that as well. So now we went over the candidates, and Jamie, at any point, chime in if I forgot, some people that are in your practice that you could think about. But with some of the things to think about when you finally find these patients with keratoconus is, how do we decide different diameters, or how do we decide if we're going to do a scleral, or do we go big, do we go small? We want to think about the patient full picture. And so, their corneal condition is one aspect. But we also want to think about looking at their ocular anatomy. Do they have really loose eyelids? Are they an older patient that has, lid laxity where the lids are hanging really low? Is a corneal GP going to work if they want to use multifocals, if the lens is sitting really low? Maybe a scleral would be better for centration to achieve those optics. So think about those things as well. Take a look if this is someone that has, some blepharons or other kind of roadblocks. You always want to take these type of things into consideration. So when you're doing your full exam, corneal condition is one aspect, but make sure you're looking at the rest of the eye. That's going to also help drive what size scleral you would use or whether you think it's going to be successful. Because if they have huge beefy pterygiums and a symblepharon and a bunch of other things, you'll probably be able to get a lens in the eye, but is it going to be comfortable? Is it going to be sitting well? These are all things to think about. Or, patients really bad ocular surface disease and they have a lot of meibomian gland dysfunction, lid wiper epitheliopathy. We have to think about, well, we'll put a scleral on and we're going to fix one problem, but really educating the patient that that's not going to be a one fix for all. They're going to still have to be really aggressive with the lid hygiene, with managing the actual dry eye condition they have, because that front surface can start to have problems if they're not addressing those things. So just making sure that conversation's still continuing based off of your exam of their entire eye. And then with anything, scleral can have complications, so talking about those complications with the patient, if they're a really high plus prescription, is this going to be the best option for them down the road in terms of hypoxia or things like that? Making sure that you're just thinking about all of these things as you're choosing lenses or maybe choosing features of oxygen permeability, different things like that. And like I said, all the labs have so many features, so many different materials. And I know there's other lectures that are going to go into that, but just always be thinking about these things when you're managing your patients. And then also taking into account, are they motivated? And I wanted that to be on there because I think it's really important. A lot of times I'll have patients where they get referred by a corneal specialist, but they're really kind of happy with their glasses, or they're really happy with their 20/40 and whatever it is that they're wearing. And they were just referred and they're not really motivated. They don't really want the extra steps. They don't want the extra help. And so it's really important that you're not going to just fit this whole patient and they don't really want to be in scleral lenses. So having that conversation, taking into account their dexterity, maybe they're going to need stands, maybe they're going to need extra assistance at home with a caretaker or a spouse, and then reviewing those costs before you even get started. Because Jamie, I'm sure you can harp on this, especially in private practice, how important that is, that you don't get burned by doing the whole thing. And then the patient goes, I can't afford that, or I'm not paying that. I wasn't aware.
Right. And cost definitely is one. But I think honestly, with me, the biggest one is a motivation. I can just think of a patient I recently saw that I had fit in a scleral lens. She was super happy. And then she just didn't come to her follow-ups for a couple months. And then finally she came back saying, oh, I only wore the contact one day because it was too hard for me to take in and out. And I've just been wearing my corneal gas perms. And so I did, one other follow-up with her. And finally I just said, let's talk about things like, do you want to wear a scleral lens, or are you happy in your gas perms? And finally she just said, I think I'm just happy in my corneal gas perms. And I said, that's totally fine. We don't need to keep doing this fitting process for a lens that you don't want to wear. So as long as the patient can see and that they're being fit, safely and comfortable, that's fine. So sometimes people might change their mind with the high maintenance of scleral lenses, even though we consider them to be, wow, you're seeing so much better. We don't know what's going on in their life, but as far as their job, their family situation, where a corneal gas perm or even like a soft lens might be better for them. And now we're just going to move forward. Oh yeah, go ahead.
I was going to just say, we see a lot of the questions coming through. Some of these, it looks like they're more fitting related questions. So we'll have our emails at the end. More than happy to reach out to you with more of the fitting aspects if you have questions on that, vertical diameters of corneal. That we're not getting into the technical aspects of fitting during our lecture. It's more about the practice management standpoint, but we're happy to answer those questions. We're both very versed in scleral, so we can answer that later at a later time. And then some of these other questions we'll answer at the end so that we can hit everything at once.
All right, great. So the next thing that we're going to talk about is setting up the ideal environment. Okay.
Oh my gosh, sorry.
So you're fine. So the most important thing, especially, in my situation where I was joining a very busy practice that was already very successful. And I think this is something that a lot of you listening can relate to. It's, how do I bring scleral lenses into my already very busy private practice or hospital-based setting or ODMD? And the number one thing that you need to look at is your staff. Your staff is going to make or break this whole system. So I always want to start with the front of the house and work back. So a lot of times I think we spend a lot of time talking to like technicians about, the technical things with scleral lenses, but the first person that's going to answer the call for your patients is your front desk. So your front desk is going to be your gatekeeper. So any patient being referred in from another office or calling based on, finding you on Google or on your website, they're going to be calling and talking to that front desk member. So it is very, very important that your front desk is aware that you fit sclerals. And I know that sounds really silly, but sometimes your office might offer so many different services. And if you're brand new to fitting scleral lenses, if the person answering the phone says, oh, wait, let me put you on hold and check. Do we fit sclerals? What is keratoconus? I'm not really sure what that is. The patient immediately is going to think, this office doesn't do this a lot. This doctor might not be that experienced. When really it's just the person at the front desk doesn't know what a scleral lens is. So in my office, like day one, because I knew at my cold start, like that is going to be what we're going to be seeing. We talked about it. We had a lot of meetings about it. So it's to the point where when patients call to schedule a scleral lens fitting, my staff is like, oh, that's so great. We see a lot of scleral lens patients here. Do you have keratoconus? We'll get you booked with a lot of one-on-one time with Dr. Kuzniar. You're going to be in good hands. And a lot of patients will say right away, wow, that makes me feel really good because I was really nervous about this situation. They don't know what a scleral lens is. It sounds kind of scary. They might have Googled it. And just having that front desk staff reassure the patient that you're in the right place. We're going to take care of you. It really goes a long way. The next thing is making sure they know how to schedule those patients. A scleral lens patient is going to require more time than a normal contact lens follow-up. So they need to have a set template to know how long do we schedule that patient. The other thing is making sure that front desk member gets all of the insurance information from the patient. And I'm talking medical and vision, because I get a lot of referrals from hospital-based systems. A lot of the hospital-based systems around me don't take vision at all. So the patient will present with their medical insurance and say, I don't think I even have vision. So just really dig deep, because sometimes those patients can have great coverage with their vision insurance that they don't even know exists. What would you have to say about that, Dr. Miller, with your front desk?
Yeah, so I 1000% agree that it all starts at the very front, at the beginning with scheduling and making sure that they're writing, notes, getting those authorizations ahead of time. In our hospital, we do take vision insurance, but I will tell you that we get tons of referrals, and if a staff member doesn't get, the right chart notes or the right authorizations, these poor patients show up from hours away and we're stuck in a bind. And it really starts with, if they're not scheduled appropriately or they're not aware of everything that we need, training those front desk people and your scheduling people is really, really important.
Exactly. And then moving on to the technicians. So the technicians, for me, are usually going to be the staff members that are going to help a lot with the application removal. That can be a huge time sink for doctors. So I think a lot of times when you're bringing scleral lenses into your practice, there's, doctors will say, I think it's too hard for my staff to learn it. I'm just going to, do all the INR myself. That is going to not be a great use of doctor time. So just really empower your staff to learn how to do that. And my staff loves doing that. They love helping the patients to get their lenses, in and out of their eyes. And they spend a lot of one-on-one time with them. They bond with them. And it's really rewarding. Also really important that they know how to do all of your imaging properly so that you can fit the patient efficiently. Some offices will even have technicians that help with fitting. I personally don't do that yet. I know, Heidi, I think you mentioned that you have a lot of technicians that will actually help to apply the lens sometimes for in your office. So that can be really helpful if you're in a really high volume scleral lens practice, is actually getting one of your technicians so well versed in scleral lenses that they can actually apply the lens, let it settle, and then you as a doctor can just go in and assess it. I think that's a fantastic step if you have really well-trained technicians. And then also just looking at, common patient question and answers. So when the patients come back for follow-ups or dispense appointments, a lot of times they're just drilling the technicians with all these questions that they have. And if they can answer a lot of those questions, that'll save a lot of your, doctor time. I'm always welcome to answer any questions that my patients have. But if my staff can already, answer common questions like, what solution am I supposed to be using again? Or which one of these little plungers do I use to take it in and out? Those are questions that I would love my staff to be empowered to be able to answer, instead of me picking up the phone, every time a scleral lens patient calls just to ask me, what do I use to clean my lenses with? It's great to have that go-to person. And then continuing with the support, your opticians. So don't underestimate the value of having opticians that know a lot about scleral lenses. So the number one reason why is because of their medically necessary benefits. So what do I mean by that? I want the opticians to know if I am using their medically necessary contact lens benefit, that, all over the chart in the routing slip, I will say, do not use their benefit for glasses, because I have been burned by that a couple of times where, I'm, great, you have great coverage for your sclerals, your fitting and your lenses, we'll just have a small copay. Fantastic. And then I bring them out to the checkout and they say, well, I want to look at some backup glasses. Awesome. Then you hand it off to your optician, you go to see your next patient. Then the next thing you know, you go to bill out your fit a day later and the benefit's gone because the optician, I had them use it on their glasses and already sent it over to the lab. And now that benefit is gone. And you're really just in a pickle where you're having to talk to your patient about that and take that benefit back. So that's number one, to say, listen, I'm using their benefit towards their scleral lenses. They can definitely still do glasses, and just kind of explain the situation to them. And then the next thing is actually the visual expectations of glasses versus scleral. So another issue that I had, especially in private practice, is patients that get glasses as a backup for their sclerals. And, as much as you can tell them in the exam lane that you're not going to see the same as you do in your scleral lenses, and they'll still, acknowledge it. You can trial frame it all you want, and then they'll go get their glasses, and then they come back and tell your optician, I don't understand, why I can't see very well in my glasses. Why can't it be like my sclerals? So instead of them scheduling a bunch of RX checks for you to troubleshoot as a doctor, have them have that same conversation up front at the dispense, that just remember, Dr. K fits you in these amazing sclerals. You're going to see fantastic. Your glasses are not going to be the same as that. And that's why you're wearing these scleral lenses. And then the last little tip I have is something called the overlay benefit. So I'm not sure if a lot of you know this, but this is a little tip. There are some different insurances where if a patient needs reading glasses, if they have presbyopia, they need a progressive over their scleral lenses. What you can often do is you can often call that insurance and get a secondary authorization for lenses for that patient. So that was something I just learned recently, a couple years ago, and it's been really helpful for my patients that, I can get their vision to be really great for far away, and then they need reading glasses over top. And instead of them, going and getting cheap over-the-counter readers, they can actually get a nice pair of progressives by pulling a secondary authorization and getting that overlay benefit for your patients. And I know you do the same thing, Heidi, in your office. And I think that's one of those hidden benefits that a lot of scleral lens doctors just don't even know about.
Yeah. And I think that it's really important too, when we're thinking of like, do I want to put the astigmatism in the contact or not? It's not that much, this or that, is that if they have that overlay benefit and, using VSP as an example, you can pull up what those diagnoses are on VSP, and it will tell you, presbyopia is one of them. And so if this is an older patient that was wanting, that needs reading glasses, but was also wanting maybe their astigmatism correction, and you just weren't sure that you wanted to put that in the contact, you could put that all into the glasses because they're going to need progressive anyways, and that benefit's available. So that's really awesome.
Yeah. And the last thing, last part of the staff is your billers or your contact lens coordinators. At my office, I am my own contact lens coordinator because I have a small staff, but I'm my own biller too. It is actually pretty easy to bill vision insurance. So don't be intimidated by billing these medically necessary claims, because I do them all the time. You can definitely learn it, I promise you. But it's just teaching your billers, whether it be a third-party biller or someone in-house, how exactly do I do, how do I bill these lenses? And there's a ton of fantastic webinars out there online, GPLI, Dr. Stephanie Wu has an awesome one too, and maybe have them watch those webinars as you're getting started in your office.
There we go.
And then looking at scheduling. So like Heidi mentioned before, it's really important to have all those authorizations for the exam materials when the appointment is made. I want to know exactly, what is that out-of-pocket cost going to be for that patient? Do they have an exam? Do they have materials? That way I have all the information up front when I'm doing my consultation with my patient to know this is your situation. This is our plan. This is how much you can expect for out-of-pocket cost, and it's done. Instead of them, well, wait, let me just, check on this in a couple of days and we'll call you and you have to come back again for a fit. You just want things as smooth as possible. Having topographies prior to the appointment, that is fantastic. I never get those from my referring doctors. It sounds like you do. I tend to not, and I just kind of do my own. And
No,
that's
I meant
totally
like
fine.
us, because
Oh,
we
yeah.
we at a hospital setting, like if it's an HMO but they don't take it in their network, we have to get us for the topo from the HMO so that
Wow.
we can do the topo. Otherwise, they show up and it's like, well, we should be doing some sort of topography. That's what I meant by that.
Wow.
Yeah.
That is something. I'm sorry for that. I know it's tricky there in California. And then looking at how much time do I block? So I get that question a lot. Myself, because I am a smaller staff and I run most of my office, I block an hour for my patients, and that way I have enough time to do the fitting, any testing that I need to for my patient. When I was in a busier office, I would maybe block 30 minutes. So I would have a 30-minute one-on-one time. You can still be efficient though if you have more than one room. A lot of times you can be fitting your patient, you can put the lens on the eye, move over to your next lane if the patient's already worked up, do a comprehensive exam there, come back, take the last measurements that you need from your patient, remove the lens, and have them on their way. So when you're first starting out, my advice is always block more time than you think because you don't want to feel rushed when you're first learning how to do sclerals. As you get going, you can start cutting that time down. You just don't want to feel like you're running behind in clinic and having issues with your, routine patients having to wait super long time because you're stuck on the scleral lens. So just always book more time than you think you need for your first few ones. And then as you get better, it just gets a lot more efficient. And as your staff helps you, follow-ups are kind of different depending on the office. So in my office, I try to have my patients scheduled 2 weeks out right away before they leave the office. So that way, they're on the books. I'm not trying to chase them down and I'm not having issues with scheduling conflictions. I know Heidi's office, you're so booked that you mentioned that you just have your patient like pre-book all of their follow-up appointments. That way they don't have an issue where they can't get in to see you. Is that right?
Yeah. So us in a hospital, at least here, we're super impacted. So we will schedule the, actual fitting evaluation, and then we pre-appoint 3 follow-up appointments already spaced out by 3 weeks so that way we make sure the lens comes in if it takes 2 weeks and they can pick it up or whatnot. But we have to do it like that. It's easier for us to cancel follow-ups than it is to get them in. So that's just the method we do. Do not do that though if you're not super impacted, because then you're going to have all of these follow-ups and like they're going to go empty slots. So don't do that unless you need to.
Right. All right. I totally agree. And then just making sure that if you have, they need to be trained, you have that in the schedule. So it's not a surprise to yourself or to your technicians that, oh, by the way, I need to pull you from a really busy day to like train a scleral lens. Like you want to have your staff to know that aware, so that way they can, coordinate that in their schedule as well. And there's a lot of super great resources that we have listed here. And I think we mentioned them a little bit more later for training your patients either at home, having them watch the video beforehand, or having your staff show them a video while they're teaching them in person as well.
Yeah, I have the Scleral Lens Education Society brochures in office, and like at that day when I fit the patient, part of I call it their homework. I hand them the brochure. I say, you're going to go to this website, you're going to watch the videos ahead of time. You're going to get your salines and everything ahead of time so that when you come in, it's not the first time you're hearing it. And you're also, mentally prepared, but then they already have kind of that muscle memory of like, they know where to go for resources. So I always say you're going to have homework.
That is perfect. And then lastly, looking at organization, and obviously Heidi and I are going to organize our offices differently. Right now I have like the tray system. So it's just like optical trays, and I'll have the patient's name on there. And then I will date on there the date that we started the fit. Okay. Because that helps me to keep in mind the warranty times, who's getting close to the end of their warranty. Is there a date from like 2 months ago? And why are these lenses still in here? We'll have to track this patient down. Why aren't they picking up their lenses? Sometimes you have to call and notify them multiple times because time slips away from them. So it's nice for me to have that right in front of me every day when I look, to just get a little quick snapshot of everything. I've seen some offices do something like the pharmacy bag system. And I'm actually thinking about moving to this because I'm using way too many optical trays right now. I'm running out of them for glasses. So the pharmacy bags is a really great option as well. And then just making sure that you're organized enough to follow up with those cancellations. So if a patient has to cancel for whatever reason, their dispense appointment, a follow-up appointment, just don't lose those patients. Whether you keep it as a spreadsheet or assign a staff member to that, Because a lot of times patients cancel because of something in their life, and then they just fall off the radar for months, and then they come back after their warranty is up. The other thing I like to do is scan their invoice into their chart. That way I have all of their parameters right on hand in case something doesn't seem right, or if I'm questioning a lens parameter, if I have it right in my chart, I can just click on a little button, and all of the parameters are popped up there.
I do everything really similarly to Jamie. We use a tray system and it's just like stacked up like crazy everywhere. But it's for us, we need that because I feel like otherwise like things are going to get lost. But we're a bigger setting, so there's just a lot more hands involved. So organization, I 100% agree with Jamie. That's like key for lenses not getting lost, follow-ups not getting overlooked, and making sure you have there before the appointment.
Yeah, and then looking at billing, like we talked about before, it's really important when you start fitting these lenses to know what you're doing with billing, because otherwise, these lenses can really give you a great revenue per patient, or they can really tank it if you're not billing and coding correctly. And we could do like a whole 1-hour webinar just about billing and coding, so we're not going to get totally into that. But some of the key points I like to mention is when you're looking at vision versus medical. If you're billing a vision plan, it's important to keep in mind that that is a global period. So they're going to pay you more money up front on day one, and then all of their follow-ups and lenses are included in that. However, if you are billing a medical insurance, a lot of people will say, well, medical doesn't pay me very much for these fittings. That's because you are supposed to be coding a level visit and all of your testing at each visit that the patient comes in. So it's important to know, even if it's a follow-up, how did I bill this patient? Did I bill them VSP or did I bill them Blue Cross? So even if, all my follow-ups, I still like to have a rounding slip. So I know, do I have to level this, or is this considered part of their global period? When I started out, I just made a cheat sheet for each plan. What codes are covered, what diagnoses are covered, how do I bill it? And then I used to look at that like every day until I got familiar with it, that I just knew it, like the back of my hand. And then looking at things like a scleral lens contract. So I know there's been a lot of talks about this as well. And I know you have a contract as well, Heidi, that it really just talks about, what we're going to do for your billing. What happens if for some reason your Blue Cross plan denies you? What happens for the patient? I like everything to be transparent about potential fees. And then looking at, prompt pay patients. So this is another question that I see a lot on forums, and I know, Heidi, you see that a lot too. Just a reminder, if someone is paying prompt pay, you can, do a prompt pay discount for that patient, but it cannot be something extreme like, you only charge a patient like, 80% off if they pay prompt pay and you're not billing their vision insurance. So just remember, in case of an audit, you should be charging your patients the same amount, whether you're billing it to vision, medical, or prompt pay. Just a little quick reminder there.
So we won't go too deep into the fitting aspects again, but we did want to make sure that everyone knew about different technology that's out there that you can introduce to your offices, and as well as what is it that is necessary to get started. And we say necessary because, if we had a perfect Christmas list, there'd be all kinds of fun toys that we'd want on there, right? But what is it that you want versus what you actually need can be a little bit different. And so what you need is you need fitting sets, unless you've got some of these fancy scleral topographers where you could do some empirical fitting, but you still end up needing the fitting set to do the over refraction. So our advice is always to, maybe get a few sets and get really good with those sets. The last thing you want is 10 different sets in your office, and every patient you're trying a new lens on, you're never going to get really versed with that fitting set, and it's going to feel like a new patient every single time. So just have a few sets in there that you can use. Split lamp and fluorescein. You need slit lamp and fluorescein so that you can take a look at the lenses. Fluorescein makes it easier to see, but you can also use fluorescein for, seeing if there's bubbles, uptake, all kinds of things. So basics that we already have in our offices anyways. And then topography, you really should have a corneal topographer, because when we go to offices or we're talking to colleagues, a lot of times they say, oh, I fit sclerals, but I don't have a topographer. That's fine if you don't have one, but you need to make sure that you're co-managing with someone that does, because at the end of the day, we're managing the cornea, not the contact. And so we need to know if they're a progressive condition, what's changing over time. And so it's really important, especially for standard of care for the patient, what's in the best interest of the patient is corneal topography. And so if you don't have one, make sure you're working with the corneal specialist where they can go get the topo done there. They send it with you when they come in, or that you have something for reference, because you don't want that to go unnoticed. And it's kind of like when I get these cornea patients and I'm like, when's the last time you've been dilated? You know, I just get referred for the contact, but they're like, oh, I haven't been dilated for 10 years. Like they just look at my corneas all the time. I'm like, what? You've got a back of the eye too. So it's kind of in the same ballpark of we're managing disease. So we want to make sure that corneal topography is being done, especially on these cones or people that it's progressive. But a want can be a scleral topographer. And I'm fortunate in my practice setting that I have two, and I love it. I feel like it's taken my scleral practice to the next level for some of those complicated patients. But even for, it's just kind of streamlined my practice. Like I said, we're really impacted. I see a lot of patients throughout the week. They come from maybe several hours away. And so having that scleral topography has helped with accuracy and maybe minimizing some of these follow-ups. And it's been really good for me with these patients that come from 4 hours away. That adds a lot of pressure. It just takes a little edge off on those patients for me. But that's more on the wants list. It's not necessary to get started with your office. And then the last thing I would say is if you have OCT, awesome. This is also like an added perk, but not necessary to fit the lenses. And I would highly encourage you not to think that anterior segment OCT is the way that we would fit a patient. This is kind of an additive to help you in the fitting process, but really slit lamp fluorescein, those fit sets, your doctor brain is what you need for fitting these patients.
Totally agree.
Anything to add, Jamie?
No, I mean, everything there, like I've worked very bare bones and I've done it for years. I've never used a scleral topographer. It'd be great if I had one, but I've probably fit like almost 1,000 lenses without it. And it's fine. Like, especially if you're just getting started. I do think it is good to have corneal topography though, or have at least some way to obtain it. But I agree. A lot of it's just slit lamp and fluorescein. I know we only have a few minutes left. Do you want to move on to looking at like how do we get these referrals? Because I think that's a big question.
Yes, and we will get there. I just wanted to say one sentence on this, and that if you have a lot of more advanced patients where maybe they have blebs, or you're dealing with corneal transplants, blebs, a lot of complicated cases where you want to really make sure you're not rubbing on anything, having impression-based lens options can be great for your office. But if you're not having a lot of that patient base, starting from where we started is great. And that's just another added feature that you can add to really take it to the next level for if your patient base is growing in that direction. So yeah, take it away, Jamie.
So referrals, I mean, this is like the number one question I feel like I get in private practice anyways. I know like you have so many patients, Heidi, it's like insane. But if you're someone like me and you're joining an office that like you have zero, you're starting from zero, how do I get them? Number one, if you're in an established patient base, like look at your internal referrals, have other doctors look at it. When I first joined my group office, they did like a data mine actually of patients that had dropped out of gas perms and hybrids. And they just called them and they just said, hey, we're offering this new service. It's brand new. I think it'd be great for you. Do you want to come in and make an appointment? And we had a bunch of people come in just by like data mining, dropouts. And then looking at, ophthalmologists. So not just your corneal ophthalmologist. Everyone thinks like, oh, I need to go see the cornea guy. I need to see the cornea guy. That everybody's going to them. So obviously you want to pay a visit, but looking at just your local ophthalmologist, okay, or your LASIK centers. Okay. A lot of people going to get LASIK when they actually have keratoconus or they have, post-LASIK ectasia. A lot of those ophthalmologists, they just think that scleral lenses are for keratoconus. They don't actually know about the other indications. That's just not something that they learn. So when I first got into town, I just went around, I mentioned the indications for scleral lenses, like, oh, if you have really bad dry eye, if you have a neurotrophic cornea, a scar, and they say, oh, wow, I didn't know that scleral lenses could actually do that. Super cool. Well, I can think of a patient off the top of my head and I'll send them right over to you. Another referral base for me.
Sorry.
Oh, yeah. Referral base
I didn't mean for that to happen.
Is actually some of the larger hospitals. So like Heidi says, like her office is super impacted. They're booked out really far. I have a couple really awesome, doctors that are around me that are just booked out way too far. And, they started reaching out. I reached out to them and said, hey, I'm here. And they've started referring me some patients that didn't want to wait 4 months, or maybe, like I mentioned before, a lot of the hospitals around me are out of network with VSP. And so if a patient has VSP, they can, you can go see Dr. K and your lenses will be covered and you can get in next week, or you can stay here and, pay more money and, wait 4 months. And a lot of times patients will just come over to my office. And then going to other local ODs. So a lot of, my friends and colleagues that are in the area that just don't necessarily love fitting sclerals, that's totally cool. Just go in there, drop off your business card, drop off some cookies, say, hey, I'm in the area, I'm offering this service. I'd appreciate it, if you can send patients my way. And then just putting your services on your website helps a lot too. Writing down that you do scleral lenses, having information about scleral lenses. That way, when patients are Googling scleral lens doctors in the area, your office will pop up. And then, Google reviews. So whenever my patients have a really good experience, I will just ask them, I'm so happy that we found each other. It would be really helpful for me if you could, write a Google review and say that you wear scleral lenses in there, so that when other patients are trying to figure out what doctor to pick, they can read your really good review and maybe, come and visit me as well. And they are always more than happy to do that. I know it seems really cheesy to ask for Google reviews as a doctor, but it's the way of life. And it's helped a lot of patients to find me because they say you have really good reviews. And, I just thought I would come and try you out as well. So what do you do, Heidi, to get your huge network of patients?
Well, I feel like you said, I have a little bit of an advantage that there's already kind of like that built-in referral because I work within, ophthalmology. So we get a lot of internal referrals just from our own ophthalmologists. But what I will say that's a little bit unique for me in Northern California is where I'm at, there's a lot of hospitals that do not offer either optometry services or they don't offer specialty lenses. And I don't know why. Maybe they don't see the value in it, but it has become a little bit of a funnel for us. So we get a lot of referrals from local hospitals too. Like, let's say they have optometry, but they don't do contact lenses there. That optometrist says, oh, we'll go to Dr. Miller over at UC Davis. She can see you. And so we get a lot of local hospital referrals. Also, because I'm in the health system and we've been doing a really good job of kind of educating the internal doctors here, either endocrinology, rheumatology, other doctors where we see them for Plaquenil, we see them for diabetes, we see them for that. So they end up coming to us for that, right? And then lo and behold, they had keratoconus or something like that. So just having these internal referral networks, sometimes you end up having patients within there, or dry eye, all of these patients are on a lot of medications. And so make sure you are connecting with your local doctors that are not just eye care providers, because they will refer to you even for pediatrics. That's one area where I've noticed now that I have a baby and I've gone to the pediatrician so many times. My poor daughter has so many ear infections lately. She actually told me, when do we need to refer people to you? And I was like, oh, I spent that time just educating her. She kind of spread the word. So now they even know like at what ages to be sending people or, what to kind of look for. So they've been sending patients over there. And with pediatrics, depending on what it is, they could be a scleral. I have the youngest, I think I fit a pediatric in a scleral, and it was related to like an ocular surface. Stephen Johnson's issue was 8 years old. So 8 or 7 years old. So it's possible, but definitely connect with them. And then like Jamie said, word of mouth, websites, make sure they're current, make sure you've got the buzzwords so that when they're searching for you, they get it.
And here's our golden rule that Heidi and I stand by is just do not steal patients. Okay. It is not worth it to keep those patients for a pair of glasses or a comprehensive exam, because here's what happens. If you steal a patient forever, that patient cannot go back to that referral source and say how awesome you are. Okay. You want to just blow the patient's mind, fit them in an amazing scleral. And then I say, you know what, I'm going to send you back to, Dr. So-and-so, make sure you get your glasses there and make sure you do your comprehensive exams there. And then that way they can go back and say, oh my gosh, thank you so much for sending me to Dr. K. I love her. And they know that you're not taking the patients. And I think a lot of times optometrists don't refer to other optometrists because we don't want to lose that patient. So just just, be respectful to your colleagues. Even with your ophthalmologist, like my corneal ophthalmologist, I could monitor the patients myself a lot of times with topography, but I say, you know what, go back to see, Dr. Chow, he's awesome. And then, he'll go back and they'll tell the staff how much they love your office. So like, it's a mutual relationship that you're doing through referral based providers.
Yeah, and that also applies for ophthalmology. You'd be surprised how many corneal specialists will refer to us for the contact lenses. And they, we make it very clear, like we send follow-up letters saying, this is what we did, this is great, go back to your corneal specialist, even though we have cornea here. We have every service here in ophthalmology. So it goes both ways with ophthalmology and optometry, but I 100% agree. Like I made that comment, oh, when's the last time you've been dilated? It's been 10 years. Oh, well, this person that referred you, but you used to see this doctor 10 years ago. It's time to go back and get dilated and do everything else, educate the patient so they get into the workflow and it just becomes second nature that I'm going to go there to do my dilations and glasses. I'm going to come here every year for the contacts. And then it becomes part of their second nature. And then they're not lapsing on either appointment with either provider.
I agree. And a lot of these patients seem to have like glaucoma and everything too. So I'm like, who's doing your glaucoma workups? No, like I'll write in the chart, like go back to this doctor for the glaucoma workup. That's not my favorite thing to do. Please go back to them. They'll run your OCTs and visual fields.
100%. So take a screen grab if you're on your computer or phone, because this is a really important slide. It's just some of the resources of where you can find information on how to get started, the billing aspects, forms. I use a lot of the Scleral Lens Education Society forms that are already pre-built. Why reinvent the wheel? And you can circle I print those out because patients, I'm in some of these support groups. And one of the biggest things they say is, I don't get enough printed material. They just told me an hour worth of information and I don't know what happened in there. So having things that are printed out or written down for them so that they can go back and kind of refresh and review is important. And Scleral Lens Education Society has a printout where you can circle the saline, you can circle pictures of the solutions, you can write the wear time, the buildup, the whatever you told them, it's all on there, and then you can hand it to them. And then they know exactly what you said, they can reference it, they know what websites to go to. I think all of that is equally important when we're talking about success with the patients. And to assume that they're going to remember everything we said when this is the first time maybe they've ever been in contact lenses is really important. But anywho, so these are all the things. Let's try to get through some questions. I know we're like short on time. And again, let me, put here these also, screenshot this so that you have our information. And if we don't get through some of these questions, for sure, email us your questions and we'll get back to you on everything. We didn't dive it deep into fitting, but we are both versed on that. We can tell you, what topographies we use or whatever. They're all great. And let's go to the beginning. So mentioned high prescriptions. What are your thoughts? Have you ever fit aphics with sclerals? I do have some aphics and sclerals. I do tread cautiously with that. And I would follow up more closely with those patients because we start to deal with thicker lenses, hypoxic issues. Maybe they have, depending on who the aphic is, if it's an adult, they might have glaucoma as well. So we're dealing with a lot of different factors, maybe other surgeries involved. So I do follow up more closely with those patients, but I don't write it off as an absolute no. What about you, Jamie?
Like you said, it depends. So I totally agree. But sometimes people are an aphic and they have a graft and like it's their only option. It's not my first option though, to fit an aphic and a scleral. It's not usually my first go-to. I think Dr. Tucker was going to go through some of the other questions that she was kind of sifting through during our presentation as well.
Yeah, ladies, thank you so much. That was fantastic. There's a lot of fitting questions, so maybe we can just have those individuals email you, but there's a couple questions about authorization. So maybe we can go through that. One good one is, how do you get authorization for a scleral lens fitting before the exam?
So I think the only way that you'll be able to do that is either if you're in a hospital-based setting like me, and maybe the corneal specialist is someone who has done that exam and they are recommending it. Sometimes we can send those chart notes ahead of time so that we can get an early auth. And that's if you trust the person that's referring, right? So if you've worked really closely, like with my corneal specialist, like we are in tandem, we know what each other's style is, what we do. So it works that way. But otherwise, you're going to need to see the patient first. You're going to have to do your own examination. And then I would recommend splitting it up so that it's not like you're trying to do the fit and the exam all in one day. Like, do your exam, get all your information, talk to them about why you're recommending what you're recommending, and then having them come back for more of that consult to fit them. And that way you can submit everything that you need, knowing after that appointment what you're going to need, and make sure that you do get the offs, because I wouldn't dispense anything without having some sort of approval, payment, because that patient might disappear and then they're gone.
Yeah. And for vision insurances, a lot of times most plans, you don't need an authorization. So I think what we were talking about as well was just pulling their benefits to make sure that they're eligible and make sure that they have coverage on their specific plan, and just reading all that fine detail.
Got it. Maybe we have one more time for one more question. Is that okay?
Yeah.
Okay.
Go for it.
So there's some interest in that overlay authorization. So does that require a special authorization, and how do you know if it's covered by a specific plan or not?
So the one that we're talking about specifically was VSP. Is that what we were talking about, Heidi? So what you do is it's kind of hidden, because if you read the VSP manual underneath the medically necessary contacts, there is a note in there saying that you can get glasses for if someone has like presbyopia or needs glasses over their medical contacts. So what I do is I have my optician call VSP and say, I am using their primary benefit for medically necessary lenses, and I am going to need a secondary authorization for lenses. And they will give her that, they'll issue that over the phone for her, and she'll write down their authorization, and they will get like their same benefits as for their lenses. I'm talking about glasses lenses, as they normally would as if they were buying glasses. Now, I did see a question in the chat. What about the frame? The frame, they will have to pay full price for. Okay. But, my patients are just super happy that I'm going the extra mile to get them like both, completely coverage basically for their sclerals and getting them a discount on their lenses, that a lot of times they're just like, I don't even care if I have to pay for the frame totally, because that's awesome. And I didn't even know I had the secondary benefit. And I haven't had any pushback from patients being unhappy that they also don't have a frame benefit. So it's just something, yeah. Would you agree with that, Heidi, as well? I think it's just VSP is the only one that does that.
100%. And if it's a patient where they're concerned about that, we always have value options versus, top of the line brand names. So frame, that's not usually something, but you do want to call ahead of time and see, because we're saying VSP, but there might be some random plan. VSP has all these different options within. So you always want to call and verify, but it is a separate off from your medically necessary benefit, which is also separate off from like your contact lens exam. So you are pulling a bunch of offs.
Yes. Yeah.
All right. Well, thank you, ladies, so much. That was so informative. I'm sure everyone learned a lot, and I absolutely learned a lot. So we'll wrap it up. If you have any more specific questions that we didn't get to, please feel free to email Dr. Miller and Dr. Kuzniar. But I also want to just mention that our next webinar is on April 12th, again, a Wednesday night. It's with Dr. Julie DeKinder giving us a talk on scleral lens fitting 101. So please join us. We're looking forward to seeing you all again in about a month. Good night, everyone.